So in about 30 seconds, it's afternoon. But so I'll say good morning to start. Dr. Katz says good afternoon. So Jacoby and Jacoby staff, thank you for coming out. To our colleagues at all the other campuses, welcome to Jacoby virtually. We're very honored. I'm Chris Mastromano. I'm Chief Executive Officer here. I just demoted myself. But you're not here to hear me. We are here to hear and welcome Dr. Mitch Katz, our President and CEO. So I'm going to just step away and let Dr. Katz come up.
Thank you. Hi everyone here at Jacoby and people who are watching from our other facilities. I'm Mitch Katz. I'm incredibly happy and proud to be the CEO of Health and Hospitals. I'm a Brooklyn boy. I grew up in Sheepshead Bay, Brooklyn. My family used Coney Island and Kings County as our two community hospitals. My older siblings who are developmentally disabled live in East New York. And my parents live just outside of New York City. So one of the great things about coming back from California is to be closer to my own family. So, it has a slightly sad part, which is that my kids are finishing school, the school term. I didn't want them. I have a 14-year-old and a 16-year-old, and those of you who have children those ages know that you don't move them in the middle of a school year. So I'm missing my kids, but I'm otherwise very happy to be back in New York City. Health and Hospitals is an amazing system. You don't need me to tell you that. It's a system that meets the needs of New Yorkers with insurance, without insurance, regardless of immigration status, that is, provides culturally competent services, linguistic capabilities, wide variety of services. There's no question about the high quality of medical and nursing clinical services at our hospitals and facilities. There are problems with what I would call the system. That is to say, I'm quite confident that people would get great services at any of our hospitals if they get in. Sometimes getting in is not so easy. Sometimes the phone doesn't get answered. That doesn't necessarily mean that the person who's answering the phone doesn't want to answer the phone. In some places, we don't have enough lines. There's no easy way for people to call in. We don't always have the appointment systems that we need so that people can get primary care, be connected to a physician. We certainly don't have yet the computer system that makes it easy to be a good doctor, nurse, pharmacist. We make it too difficult for people to do their work in the ways that we all want to. So I hope that one of the things that I can add and bring to the already good care is a system that functions more easily, that makes it easy for us to do the right thing as clinicians, that makes it easy for our patients to get appointments. I'm a primary care doctor. I'll have an outpatient practice probably at Gouverneur. That's the clinic closest to the office. I hope to work on the inpatient service here at Jacoby and at our other acute care hospitals. I've always enjoyed doing some inpatient work. So part of what I hope to be able to provide is system help. For example, I found the phone is talking back to me. I found electronic consultation systems to be a great way of connecting primary care doctors like me to specialty physicians. In Los Angeles at the time that I left, we were doing 16,000 electronic consultations a month. And it drove down the specialty waits, which were often when I got to Los Angeles, 9 months, 12 months, 15 months for appointments, to weeks for almost every service, because we had such an efficient electronic consultation system that a third of the visits didn't have to happen. And when you eliminate a third of the visits, then all of a sudden you have a great deal more capacity. So I'm hoping that we together can do some of the system things that enable clinicians to do a better job. I feel very strongly that the purpose of the central office is to support the work that goes on at the hospitals and clinics. That's what I'm interested in. I'm not interested in being a bureaucrat or an administrator. I think of myself as a primary care doctor who likes to make systems work well for patients and for the people who work in it, which means that we have to figure out all the ways to make life better for the people who work for us so that we as healthcare providers can do a better job. As healthcare providers, we don't make anything, right? There's no product. We don't make widgets. We don't make cars. All we have to offer is ourselves. And we are much more instruments of healing, much better able to connect to people, to make them feel better when we ourselves are not stressed out, because if we look up for more than a minute, all our notes disappear on the computer screen, or, it takes 35 minutes to find the person who can refer our patient to the appropriate place. Right. I mean, I've certainly lived all those frustrations. My entire career has been spent in public hospitals in San Francisco and Los Angeles. So I have a good feel for both the challenges of public hospitals and of, their amazing successes. I want to say a little bit about money because, like the nuns, I'm a big believer that there's no mission without a margin. Health and hospitals has the opposite of a margin. We have a very large hole in our budget. It is a solvable problem. A lot of the hole in our budget comes because as an institution we're not great at billing, so that of course the city appropriately needs to provide us compensation for caring for uninsured people, no question. And the city is quite prepared to do that. The problem is that we have developed a large gap in our budget because the city is also covering the costs of caring for people who are insured when we're not doing the best job billing. So if we're not billing for the services to insured people, and this is not a system that has historically billed, then you get a very large gap as we've moved into a world where people have insurance instead of the government paying hospitals for caring for people who are uninsured. And I very much believe in that you should empower patients. You should give them insurance. You shouldn't say, go as an indigent person and then we'll pay the hospital at the back end. People should have insurance. They should get to choose. Middle class people get to choose where they go. Low income people should get to choose where they go. But we have to have the ability then to bill for those services. And we can't be saying, oh, well, we've never billed. That's not something we do. We also have to make sure that we have the complement of services that includes not only those that don't pay well. Health and Hospitals is a leader in providing services that don't pay well. I'm happy to provide those services, like behavioral health services, not well reimbursed. I'm very happy to provide those services. Those are the kinds of patients I've taken care of my whole life and that I love taking care of. But I'd also like to provide services that do get paid well. And I do not wish to just refer out all of those services, because then we don't have the kind of resources to take care of the people that we want to take care of. So I see it as something that we can overcome. And as we overcome it, I will then be able to bring resources of doctors, nurses, social workers, pharmacists to the many places in our system where I know we don't have enough of those. So I am quite aware of the understaffing. I'm quite aware of vacancies. But until we can demonstrate that we have a model that will close the gap, the controller's office will appropriately at the city level hold all new positions. And you can't blame them. Right, they're responsible for keeping the city from going bankrupt. So if the only lever they have to keep us from running a large deficit is to hold positions, they're going to hold positions. But we can turn that around. We can appropriately bill. And when we can appropriately bill, we can increase our capacity, especially in the outpatient areas. And when we have sufficient capacity in the outpatient areas, we can take on new members. People have said to me, oh, Mitch, I'm happy to help. I think we can recruit a lot of new members to health and hospitals. And I have very mixed feelings. On one hand, I'm like, that's wonderful, that's terrific. But then I also feel, but if they call and there's no appointment for them, all they're going to think is that we're not a very good provider. So we're stuck in this trap where we have too many vacancies, so we can't take on new people, which means we can't take on new revenue, which means we can't close the gap, which means we can't make things better. So I'm determined for us to break out of that. It is an entirely doable, solvable problem. It's been solved in other places. We too will solve it. We will go on to a modern computer system. We will bill for those people who have insurance. We will make sure that those people who are uninsured have been checked to make sure that they're not eligible for any form of insurance, right? So that we bring in the maximum dollars. And the things that at the end of the day that I care most about is whether or not we're providing great care to the people who depend on us. I very much feel people can make healthcare much more complicated than it needs to be. And people can bring in all kinds of acronyms and VPM and value-based and, we're capitating this and we're risk-taking that. But to me, it's always been about the doctor who cares, the nurse who cares, the social worker who cares, the pharmacist who cares, the receptionist who cares, the people who realize that the act of providing medical and nursing care is showing people concern. Often diseases don't have cures. Often, we can't, give someone a medicine that is going to make them well. But we can always show our concern. We can always treat people like they're our mother, like they're our brother. Every patient who's ever walked into my exam room, to me, is my responsibility, and I will take care of that person as if they are my relative, and I will do whatever is necessary. And I want to make sure that we as a system are doing that, not just because the doctor knows what she's doing and not just because the nurse knows what she's doing, but because we answer the telephone and we can give an appointment and we can do all of the other things that systems are able to do. So with that, I'm going to stop. We're going to do questions, and they don't have to be questions. They can also be suggestions. They can be comments. We're going to do it both from this audience, and we also, I'm hoping if our technology is working, then people are able to submit questions from the other facilities. We have who has the walking mic? Okay, we have a walking mic. Thank you. What is your name?
Suzanne.
Hi, Suzanne. So Suzanne is happy to bring the mic to you. Do we have questions yet from the audience at our other facilities?
We have one.
Okay, well, why don't we do the one and someone wave to Suzanne and she'll come your way.
Okay. From Coney Island, how do you see substance use disorder evolving in NYC Health and Hospital's future?
So first, hi to Coney Island, and thank you for taking care of my relatives. For I learned in the process of talking to my mom about coming to health and hospitals. I had known about my immediate family who had gotten care at Coney Island. I didn't know that my great-great-grandmother, who of course I would not have met, had gotten care for a broken hip at Coney Island, which was the treatment at the time apparently was sandbags, which immediately made me wonder, did they get the sand from the beach? Right, I mean, that's one of the nice things about being Coney Island. So, our country is beset with a opioid epidemic. as well as very cheap heroin, very cheap fentanyl, which are killing people, literally killing people. I know the mayor announced that in New York City, more people have died in the previous year from opioid addiction than from homicide and car accidents together. This is horrible. I see us as being a leader in that treatment. I think that there has been a movement in the science to show that medically assisted treatments make a huge difference. And so I believe that there will continue to be a role for 12-step programs and supportive milieus. But it seems to me it's always better if you're counseling someone if they're not simultaneously craving. And so I want us to increase the number of buprenorphine prescribers across our system. How many of you can prescribe buprenorphine? One there, one there, one there. I was very impressed. I was at Metropolitan yesterday, and the head of the emergency department told me that he had become a buprenorphine prescriber. And I thought that was really very sort of forward thinking. And he said that what had convinced him, because actually I think he's the first emergency room doctor that I've met who was a buprenorphine prescriber. He said what convinced him is someone said to him, as an emergency room doctor, if someone had diabetes, would you tell them to come in 3 days for an appointment for insulin, or would you start them on insulin? And he thought about that and said, okay, well then I should be a buprenorphine prescriber, because if somebody comes here and they have an opioid addiction, I should start them on the appropriate treatment and arrange for their follow-up. So I think it's an area where health and hospitals has a special competence. Suzanne?
Hi, I'm Sydney. Welcome.
Sydney, where do you work in the hospital?
I do clinical trials here in the research department.
Great.
So my question is, what is your position on research and how do you feel about clinical trials?
So Cindy, you know, I'm a big believer in teaching hospitals in general. That the research is very compelling, that teaching hospitals like Jacobi provide a higher standard of care than non-teaching hospitals, and that research is a great way for people to have access to treatments that they otherwise would not have had. I do like in research portfolios to try to make sure that the research is aligned with the needs of the patients getting care at that particular institution. So I particularly like research that addresses what the needs are of the patients at that place. While we're looking for another question, I'll tell you something nice that as I was leaving Los Angeles, a patient advocate, Anthony Wright, that I had worked with for many years, California Patient Access, he introduced me by saying that he was sorry that I was leaving Los Angeles, but he was very glad that it was Health and Hospitals, because he grew up in the area right around Jacobi, that this was his family's hospital, and he talked as an immigrant about what it meant to have a public hospital that he and his family could go to, where people accepted them, where the care was affordable, where people spoke Spanish, but also the pool, and what the pool meant to him and his friends. So I thought that was a very sweet. So he was pleased that if I had to leave, that at least I was going to try to work with helping a system that he felt was very special.
Good afternoon, great afternoon. I'm Michelle Webb.
Hi, Michelle.
Representing nurses through New York State Nurses Association.
Wonderful. And
I'd like to welcome you to being #1. For all the years that you were in Los Angeles at #2, now you have graduated to #1, and welcome.
Thank you. That's very sweet of you.
Well, I love Jacobi Hospital, and I've worked here for many years, for many decades, and I've worked in the operating room, perioperative services, and we would like to see that we can retain the staff that we recruit, and we've had retention problems throughout, and we've had vacancy problems throughout, and we would like you to look forward to Jacobi becoming and that place where nurses loved, or all staff loved to come to work. Jacoby is powered by union power, so I say power to the people who maintain services for the patients here at Jacoby, and we're looking forward to your help to maintaining the nursing forces that put their hearts and souls and blood, sweat, and tears on the line on a daily basis, because we are critically understaffed, especially in critical care services, and I welcome you.
Amen, Michelle, and I agree. And we want the staffing to be at a level that both it provides the highest level of care to patients and that people feel that they can deliver high quality care. It's a terrible feeling, whether you're a doctor, a nurse, a pharmacist, a social worker, to go to work and feel you can't do the kind of care you want to do because there are not enough people or the system doesn't support it.
Good morning.
Good morning.
Welcome, Dr. Katz.
Thank you.
I'm Shaniqua.
Hi,
I'm
Shaniqua.
a behavioral health nurse here in Jacoby. This morning, the Nurses Association met with staff pertaining to concerns in promoting safety in the work environment. And I wanted to invite you in creating solutions to improving our safety in the work environment.
I think that's great. And I look forward to working with you on that and to figuring out all of the ways people come to work wanting to do a good job. None of us want to make a mistake. None of us want to hurt a patient. It's all about making it the system such that they support us providing the best care. Do you have a question from?
I do. Wait times is a problem throughout our system. Some patients wait up to 8 hours to see a doctor. And do you have any thoughts on how we can tackle this problem?
So hi to Lincoln, and the question is about wait times. And none of this, is new to you as people who've lived the life in a public hospital. These are problems that are common. Often they're solvable. You have to, though, figure out what is the real problem. So when I was, I think, 2 weeks into my job at Los Angeles, a friend of mine had his relative had come to one of our hospitals in Los Angeles. The gentleman had cancer, was pretty sick, came for his 9 o'clock appointment and wasn't seen till 4:45. So I was really distressed. He was an older gentleman. He had cancer. He was made to wait all day. And when I started making initial calls to find out why this man had to wait all day, the first answer I got was, well, we were really busy. And I said, no, that doesn't actually explain it, because if you had given him an appointment for 4:30 instead of for 8 o'clock, he would have waited 15 minutes, right? So you can't just explain why you saw him at 4:45. So, one part of fixing this is making sure that actually our appointments reflect reality. And what's interesting, in Los Angeles, we had a lot of success with this. We didn't do anything other than to change the appointments to actually fit what we were doing. So another similar solution that worked for us for late appointments is one part of the solution. I had a clinic that was known for running late. I said, when do you finish each day? They said, we usually finish at 5:30. I said, when is your last appointment? They said 3:50. Well, why do you give the last appointment at 3:50 if you never finish till 5:30? Well, we want to try to finish earlier. Okay, well, but do you ever finish earlier? No, we always finish at 5:30. Okay, well, so if you gave the person who you give the 3:50 appointment, if you gave them a 4:45 appointment, you would just shave an hour off their wait time. These examples may sound trivial, but often they reflect the question, which is a broader question, is, are we focused on the patient? Is it about our system, what our system can spit out, or is it about what our patients need, right? If it's about what our patients need, then we have to think about, what is our capacity. Sometimes people wait because we don't have enough appointments. That's a different issue than why people wait all day. If people wait all day but are seen, you cannot argue that it's because you're busy. It's because we haven't figured out how to make the appointments run in a sensible way. So I want to work with people on, what are the ways to do scheduling? What are the ways? You have to think. There's some people who don't want a appointment. They want to walk in. Okay, and so then you have to create one group of walk-in, one group of appointments. There are people who we as doctors or nurses, we give appointments to because we want them to be seen, but they're not actually interested in being seen, right, for chronic care. And then we mess up our own schedules by filling it with people who actually know they're not going to follow up, but they have no choice. If you say to someone, I really want you to come for your appointments, and here I'm giving you an appointment for the gastroenterologist at 2:25 next Thursday, they can't actually say to you, no, I'll never come, right? They just take the piece of paper, but then they don't come because it's actually not their need to see the gastroenterologist from their point of view. They might need to see them, but it's us, right? And so figuring out how do we work with people, always starting where they are. Do we have hey.
Yeah, hi, Peter Mabey.
Hi, Peter.
Neurology. Hi, I'm on the stroke team here. So stroke is undergoing kind of very rapid evolution in terms of delivery of acute care.
Was the evolution a pun?
Yeah. Yes. So anyway, I'm wondering what you see the organization's philosophy towards delivering, rapidly emerging new treatments that require investment, upfront costs in interventional procedures, things like that, that we currently tend to refer out of our system. And in budgetary times where it's difficult to do those upfront investments, it's understandable that we hold back and wait, but we're just losing ground and other places are getting more and more patients. And those are possibly money-making interventions to offer. So I'm just curious how you envision trying to organize our thinking about that.
So Peter, it may be understandable why systems that have scarce resources don't do it, but ultimately it's a death spiral. We can't, one of the things that I feel very strongly about in coming here is maybe I'm wrong about what I think health and hospitals needs to do, but one thing I'm not wrong about is if we keep doing what we've been doing, we're going to have massive closures. There is no way to continue our current practice and succeed. So maybe my thought of, okay, now is the time that we have to make sure that everybody is enrolled, even if it means having more patient insurance enrollers. Now it means we have to do a better job of billing, even if it means we have to hire more people to bill and more people to code. We have to have a computer system that supports that. And we have to recognize that certain procedures pay better than others. And if you do behavioral health, which again I love, but pays poorly, happy to do it, but then you send away all of the things that pay well, how are you going to keep doing behavioral health? And the answer is you're not. It's not going to work. We cannot. The best estimates, going forward is that we need about $3 billion a year of city subsidy. And this is too large a number. And so, yes, sometimes in business, and again, none of this is like that difficult. Every business person will tell you that when you open a business, you often have to spend money at the beginning in order to make money. And what we do is no different. It doesn't mean that every expense is a good expense. You do actually have to look and see, okay, if I spend this, what is the return of investment? But I feel that the way things have been handled is because resources are scarce, we can't do that, even if doing that would actually bring more dollars. So I do want to support stroke care here. I would like to support our ability, is your cardiologist Seth here? No, I've talked to him about, can Jacobi be a STEMI center? I mean, angioplasty is a well-reimbursed common procedure. We have a cath lab with capabilities of doing a lot of endovascular procedures. Why wouldn't we be a STEMI center? Why would we send people away? So I intend to make sure that we, with discipline, with each thing, what does it cost? What's the return of investment? How does it fit with what our population needs? We may not be able to do it in every single hospital, and we shouldn't do it in every single hospital. But certainly in a place like Jacobi, which is already a trauma center, we could do a lot more of these kinds of procedures because we already are running 24-hour physician staffing at a very high level.
Gregory Shaw here,
Hi, Gregory.
telecommunications supervisor. Here at Jacobi, we outsourced a lot of programs and services. Do you see us retaining those programs and services back on the campus?
So let me say in general that I'm on the question of bringing contracting in services, bringing services in and not contracting them out, that I am a diehard, pure public service guy. I always prefer my own staff to do things because I think that that's where the commitment to a place like Jacobi comes from. That consultants come and go, registry people come and go. I want the people who want to live Jacobi, who want to live our mission. So I always start with the assumption that we can do it. Occasionally it turns out that there is some very specialized thing which for whatever reason we can't do. But that in general, I think we brought in the 7 years I was in LA about 1,500 increased jobs into the public sector, even though when I started in Los Angeles, we had a deficit. So again, it was much the same. So we had a deficit. We weren't hiring nurses. We were using a nurse registry that was more expensive than hiring nurses. But people somehow, right, again, it's this bizarre, we don't have enough money, so we can't let the items through. But then, of course, you need the nurses, so then you go on registry. And then what's even worse is you pay more, but the actual nurse doesn't get the money. Right, a third of the money goes to somebody else. Right, so I don't believe in that. But I will point out, just so people understand the timing. I have to be able to demonstrate to the city controller that we are getting a handle on closing the gap through better billing and bringing on paying patients before they're going to give me free rein to hire. And I experienced the same thing when I first got to LA 7 years ago. And now the LA deficit that I had of 260 million seems kind of quaint, right? Like, now it's like, I can't even believe I thought that was an issue. At the time, 260 million seemed like a lot of money to be behind. Now I'm like, 260 million, what was I so stressed out about? But when I first got there, the thinking was the same. You can't do anything, we're in deficit, you have to figure out how to cut. But by showing how to bring in more revenue and that I understood the idea that yes, of course, at the end you have to pay attention to your bottom line, but cutting isn't necessarily the way you save a system. I mean, that's another thing that I feel very strongly. If you look at health and hospitals as a whole, the city subsidy is spread across our system like peanut butter. So even if you were crazy enough to think that you could solve this by closing things, it wouldn't actually work because the subsidy isn't in one place. See, it's very different than the way private hospitals tend to think. They'll look at their services and they'll say, okay, well, we make money on these 4 service lines and we lose money on these 2, so we'll close these 2. That is actually not how it works in H&H. We don't make our cost right now anywhere. So everywhere you would look, you'd find a gap. So you can't just say, okay, well, I'll just close this and then everything will be fine. It won't work. The system fundamentally has to be able to attract paying patients, bill for paying patients, and stop sending away patients who have the services that pay the best. And it is doable. This is not rocket science. This is not nearly as hard as the work that many of you do every day, right? I mean, one of the other things I often think how strange it is, you have a place like Jacobi, which is a trauma center, which is able, and I know from looking at the data, that's able to take somebody who's pulseless, right, and bring them back to life. But we can't bill? How does that happen? I enjoyed my time in emergency room. I recognized that I was not cut out to be a trauma surgeon. I don't have that set of skills. I greatly admire the people who do it. I find that really hard. I understand why it's really hard to be a good trauma surgeon. It's not so hard to bill. It really isn't. I know how to do it. Other systems do it all the time. It's just like it's not very hard to answer a phone. It's not very hard to give people an appointment. Not anything like what it's like what people do every day here in saving people's lives. That part is hard, right? Being a hospice nurse is hard. Learning how to bill, not so hard. Other people have done it. We will do it too. It may not be how we grew up. And there's nothing to be embarrassed about, right? If you're a public hospital and you traditionally, all of your patients didn't have insurance, it wouldn't make any sense to devote your resources to learning how to bill, right? It would have been a waste of money. But the world changed, and somehow health and hospitals didn't quite, I don't know, nobody quite got that memo. I'm a little off on the timing, right? That the world changed, people got insurance, and now there's no supplemental payments because people have insurance, but you only get the money if you actually bill. So somehow that switch didn't quite get thrown, but as I say, so much easier to fix than to save a life, which I'm sure is happening today at Jacobi and in all of our hospitals across health and hospitals. There's someone at the left back near the exit door.
Hello, I'm Noah Romo. I'm the director of the Pediatric Inpatient Service here. I just wanted to know if you could elaborate a little bit on your long-term plans for inpatient and subspecialty pediatrics here at Jacobi and the system in general.
Well, it's a good question, and it'll give me a chance to address. So the question is about inpatient to Jacobi, which I'm going to generalize to inpatient pediatrics across our system, and maybe also suggest how I think we go forward in general. So we have 11 acute care hospitals, we have 5 skilled nursing facilities, and we have a large number of outpatient facilities. When it comes to primary care, you want primary care as close as possible to where patients live and work, because that's how people choose where to go for primary care. When it comes to anything that is an unusual event, including, a child being hospitalized. I'm very proud to have gotten my kids to 14 and 16, and thank God neither of them have needed ever to be hospitalized. Hospitalization is a relatively rare event in a child's life, not as rare as some things, but relatively rare event. What I want to, if my kid needed to be hospitalized, what I would want to make sure is that the hospital had the necessary resources to take care of my kid. And depending on what was wrong with my kid, that would mean not just like a wonderful general pediatrician, like I'm a general internist, but if my kid needed dialysis, that you had a pediatric nephrologist, that if my kid had a heart problem, that you had a pediatric cardiologist. And we do not at health and hospitals have the resources to provide that level at 11 places. And we are not providing that level at 11 places. I feel for clinical care that we need to figure out how to, if you want to use consolidate or coordinate or group our resources, not to save money. Because again, the money savings from, Jacoby is going to continue most of the expenses, whether one service moves or doesn't move, or you grow here or you go. That's not where the big dollars are. But I would like to coordinate, consolidate services like pediatrics for the good of the kids. Now, then the question is how? How do you do that? And at least what I'd like to suggest, and it's I hope you'll be at the meeting, which is I think your next pediatric council meeting, which I think is February 14th at 8:30, if I'm remembering right. What I'm going to pose to the pediatricians is, I'm not a pediatrician. I know that having 11 acute care services, some of which have an average census of 1, is not the best way to provide care. You are the pediatricians. I'm not doing this to save money. Figure out what is best for kids. You all went into this because you care deeply about kids. I know that it's always hard to give up things. And it can be hard to give up things for the very best of reasons. Like, well, but I love the inpatient pediatric service, and my nurses love it, and those are all great things. But for the sake of the kids, we shouldn't have 11 services. And I raise it in this way because what I do not want to do is I don't want to be in a position where I say, okay, well, we're going to have pediatrics at these 5 places. And then a bunch of pediatricians get up at the city council meeting and say, children are going to die because this is not the best care. Right. And so my view is you do things to do the right thing for the people you're caring for. The group that's, from my point of view, should be charged to do that are the pediatricians. And you all need to figure out how to do it. And I'll be disappointed if in the end it doesn't happen simply because people can't let go. Because I know there is broad agreement among the pediatricians that there shouldn't be 11. There's just not broad agreement on where it should be. Right. And I get why that's hard, but somehow you guys and women have to get to that. I'd say the next one I want to do, because I mentioned it, is around cardiology. So I would like I'd like several of our hospitals to get the capability, besides Bellevue, which already does, of doing angioplasty and being STEMI centers. But we can't all be angioplasty and STEMI centers. I want the cardiologists to get together and figure out what makes sense. And I feel, well, these things can become political in unpleasant ways. If I'm always the one saying, look, my pediatricians, thinking only of what's best for their kids, came up with this plan, who's going to oppose it? Like, what do you say next? Your pediatricians are wrong? But if I'm not in that position, if it's me who's driving it and saying, I've chosen these 5 sites, then people are going to say, you're not a pediatrician, you don't know what our kids need. So I want to try to use the clinical councils to drive the right regional services. I think one thing that's worth doing at my system level is to think for each hospital, what is their best mission, which is another way of helping, right? So maybe this hospital grows this, but stops doing that, while this hospital grows this and stops doing the other, so that nobody feels that they're being diminished, but rather what we're doing is operating as a system, and you join together so that if we suddenly go from 11 pediatric services to 5 or 6, then each one is better staffed. Again, because this is not about money. I'm not doing this to have fewer pediatricians. I'm doing it so that if we only have one, pediatric nephrologist, the kids get to benefit from that nephrologist wherever they go. Hi.
Good afternoon, Dr. Katz. My name is Chalice Pena.
Hi, Chalice.
I'm from Central Office Internal Audits, actually. My question is from the perspective of a Staten Island resident. I'm a long way from home, from Staten Island, an area that has been historically underserved by health and hospitals. On behalf of the community, we're so excited and looking forward to the new Gotham Center.
Yes, very exciting.
Would you be able to speak a little bit about the plans regarding the Gotham Vanderbilt Center?
Bill, do you want to come up and offer more details than I can do about the Staten Island Center? All of you know Bill Foley, who does an excellent job over our acute care hospitals.
Do you remember me?
Oh, that's right, I forgot. And who was previously at Jacoby.
So over the holidays, some of us actually went to Vanderbilt and looked at the site, which is still under construction, but almost ready for completion. And I can tell you, it's really impressive. It's going to be a full-service ambulatory center. It's going to be very comprehensive. I think it's in a great location. Providing primary care, specialty care, and we're currently in the process of recruiting staff, physicians and nurses and staff for the center. We anticipate that the center will be open in March.
Great. So. Okay. Let's do one more question, then I'm going to walk around and meet some more people at Jacoby. We'll have more opportunity for town halls. We have a question in the back. Hi.
Hi, good afternoon, Dr. Katz. My name is Monica.
Hi, Monica.
Hi, I work in finance patient accounts.
Great.
And welcome.
Well, we're going to grow finance and patient accounts, Monica.
I wanted to tell you that it's so very refreshing, your support and your advocacy for the public health insurance for the Affordable Care Act, and being in the position of applying patients for health insurance. I was interested in knowing what ideas you can share in regards to when we apply patients for health insurance. It feels so gratifying to help a patient in that capacity, and then from there the patient decides to go elsewhere, and they go outside of H&H. I mean, patients have choices, which is great, but what ideas can you share so that we can try to minimize that?
Sure. So Monica's question, which is a key question, is we help people to get insurance and then they leave us. The most important thing is, can they stay? Well, if you call right now for a new patient appointment, depending upon where you call, you might find that you can get one and you might find that you can't. And one of the things we need not only to make sure you can get it everywhere, but we're not yet at the level of a call center where we can tell people, oh, well, we don't have appointments here, but we could give you an appointment over there. I think another key issue, and I don't know how many of you know this data, number one reason why people choose where to go, what insurance to take, and it's true for all of you as a demographic, is doctor, right? People want to know, is their doctor on the plan, right? We don't do as good a job as we could do on connecting doctors or nurse practitioners or PAs to actual patients, the process of empanelment. It's mixed. I don't know what it is at Jacoby, but I know across the system it's mixed. Some places are doing a really great job of connecting people, and some places it's a lot looser. But I will tell you that when that connection happens, patients never leave. A patient will never leave a doctor or nurse that they are connected to. But if you don't have that form of connection, you have a problem. Of interest, number 2 is parking. So I always thought it was interesting. Number 1 is relationship. When you choose a plan, relationship to your doctor. Number 2 is ease of parking. So I've been instructed to finish on time, in part because of the video stuff. I'd like to conclude by saying helping health and hospitals to have a bright future is not up to me. It is very much up to us. This is not a one-person job. But I am also not an autocrat. I'm not somebody who likes the office. I like the clinic. I like the hospital. I like directly working with doctors and nurses. I like thinking about real patient problems. I can't stand the various health service acronyms. I'm really focused on the people we take care of and what do we do to do that better. And I look forward to working with all of you. And the very best ideas always come from the people who are doing the work, right? Because how else could the best ideas come from, right? There is nowhere else. And everything I know now about health and hospitals after 3 weeks is because someone told me about some patient's experience. And so I know that together we can make sure that health and hospitals not only survives these challenging times, but that we grow and that we're there for our patients in ways that we currently can't. So thank you so much, and I look forward to working with all of you.